I recently read a piece about Donald Trump arguing that he's basically a walking symbol of what the writer called the age of ADHD. Can't hold a plan for more than a few days, rambles for hours, changes his mind on major policy mid-sentence. And the writer's line was, if he lived in Britain, he'd probably qualify for a disability payment on the spot. Now, I'm not here to diagnose the President of the United States. That's not really the point of the video, but it got me thinking about something I actually do think about a lot as a doctor, which is, what is ADHD really? Is it one thing? Because the way we talk about it right now, online, in clinic, in schools, it kind of sounds like it's covering at least two completely different phenomena and just calling them the same name. So I want to spend the next 4 videos, actually including this one, actually going through the evidence on this properly. It's not a hot take, it's not an everyone's overdiagnosed rant, and it's not the opposite either. I'm going to look at the neuroscience, I'm going to look at the medication data, which actually surprised me when I read the studies, and I'm going to look at what actually helps, especially in kids, versus what's just wellness culture noise. This is video number 1 of 4, so let's start with the basic shape of the argument. The numbers don't add up in the way that you'd expect. Here's a good place to start because it genuinely is a bit strange when you sit with it. Globally, somewhere around 3 to 4% of adults and about 5% of children meet the clinical criteria for ADHD. And that's the actual diagnosable rate, roughly consistent with WHO and CDC figures. And I'll say roughly because these numbers do shift a bit depending on which country and which criteria you're using. But then you look at other numbers and the gap gets weird. There's an NHS task force report, and I'm going to flag that it's their figure. It's not something I've independently verified against raw data. That estimates 20 to 34% of young people who are not in education, employment or training are likely to have ADHD, and that most of them are undiagnosed. Now that's clearly not a rounding error away from the 5% figure that I mentioned earlier. Something else seems to be going on in that gap. So broadly, when you dig into this, you'll find 2 different camps, and honestly, both have real evidence behind them, which is what makes this interesting rather than a simple who's right argument. Camp number 1, ADHD is real, lifelong neurodevelopmental condition, and for decades we've just been bad at catching it, especially in women and especially in adults who were never assessed as kids, because in the 80s and 90s, the stereotype was of a hyperactive 8-year-old boy, and that was that. A huge amount of the rise we're seeing now is just a correction. People finally being seen properly. And I'll come back to this camp properly in video number 3 because there's actually a researcher I want to bring in about this who represents it really well. Camp number 2, and this is the argument from the piece that got me started on this whole series, is that a lot of what looks like ADHD right now is actually a culturally produced thing. Constant stimulation, infinite scrolling, notification culture has genuinely shifted what our brains consider a normal baseline of excitement. So more people are behaviorally distractible without necessarily having the underlying hardwired condition. And here's the bit I actually find clinically useful. It's not just philosophically interesting. The writer of the piece that I mentioned, her name is Kathleen Stock, and she draws a distinction that I think is genuinely a good diagnostic question, even if you don't buy the whole argument. She says that real lifelong ADHD isn't really a deficit of attention, but it's almost the opposite, that the mind gets hijacked by every stray detail, every sound, every thought, all competing for attention at once. Plus there's often this involuntary hyper-focus on some narrow, specific interest that just swallows hours. People describe it as actually losing the remote control to their own mind. Not choosing to be distracted, but having it happen to you. Whereas the culturally driven version, she argues, doesn't usually come with that involuntary hyperfocus. And this is the sharper point. It often has some kind of a payoff, a reason, a social reward, a novelty, avoiding something difficulty in your actual life, which makes it, in her words, rational, even if it's self-defeating. You could, in theory, train your way out of it. The other kind is a lot harder to just train your way out of. Now, I want to be really clear about something before I go further because I think it really matters. None of this is me telling you or anyone watching that their diagnosis is not real. That's not what this series is for, and it's not a thing that I'm remotely qualified or honestly willing to do over a camera. What I am doing is going through the actual clinical evidence with you the way you'd want a doctor to. So this is the part where I'm going to slow down a little bit because this is where I think a lot of the popular explanations get slightly wrong in a way which is definitely worth correcting. The line you hear constantly is ADHD brains don't have enough dopamine. It's everywhere. It's on TikTok, it's in pop psychology, books, and it's really not quite right. The current research points much more toward dopamine dysregulation, meaning that how dopamine is being used and signaled rather than as a flat deficiency of dopamine. There isn't strong evidence for people with ADHD simply running low on the stuff. It's more about how efficiently the system is regulating it. There are also real replicated structural differences in the brain. Weaker function in the prefrontal cortex, particularly on the right side, that's this area over here, which matters because the prefrontal cortex of the brain is basically your planning and inhibition center. It's what lets you hold a goal in mind while you ignore everything that isn't that goal. There are also some consistent findings of reduced volume in specific areas of the brain, in an area called the right caudate nucleus, in a part of the cerebellum, part of the corpus callosum that connects the two hemispheres of the brain. Now, these are not one-off findings. They show up across multiple studies. And on the genetic side, two genes come up again and again. DAT1, which codes for the dopamine transporter, and DRD4, a dopamine receptor gene. It's worth saying this plainly, ADHD is polygenic, which means it involves multiple genes, and these are the most replicated genes associated with it. They're not the only cause, they're not the sole cause, and there's definitely not a gene that you could test for and get a yes or no answer. So here's a limitation. None of that gives us a blood test. There's no scan you can do on an individual person that says definitively, yes, this is ADHD. Diagnosis is really entirely behavioral. It's done through an interview, it's questionnaires, it's clinical judgment. And that's not a failure of the science, that's just genuinely where the science currently is. And it's exactly why the cultural argument from the first half of this video doesn't have a clean neuroscience rebuttal waiting for it. The biology gives us a real physical mechanism for attentional dysregulation, but it doesn't hand us a tool to cleanly separate someone who's born in this way from someone who is shaped this way by an iPhone, which actually connects to something genuinely uncontroversial in neuroscience. Your brain circuitry gets shaped by chronic patterns of stimulation. That's not fringe, that's just how neuroplasticity works. So an environment of infinite scrolling, constant notifications, endless novel content, that can plausibly train dopamine reward circuitry into something that behaves a lot like ADHD in people who don't have the underlying congenital condition. That's the actual physical mechanism sitting underneath when people are saying we're all a little bit ADHD now. It's polygenic, meaning it involves multiple genes, but it's also multifactorial. Now, here's something I think almost every explainer on this topic leaves out, and it's actually one of the more clinically useful things that I can tell you in this whole video. Having the genetics for a condition isn't the same as having a fixed, unchangeable outcome. This is true across huge parts of medicine, not just psychiatry. Genetic predisposition and environment interact, and the environment side of that equation often has more room to move than people assume. For ADHD specifically, that means it doesn't just involve multiple genes, it's multifactorial. There's a cluster of ordinary, physiological, modifiable things that measurably can shift where someone lands on the severity of the spectrum. So I want to go through some evidence on a few of these properly because I think that this really deserves more than a passing mention. Starting with omega-3 fatty acids, because I know a lot of you have heard me talk about this before. I've actually got a full video that goes deep on just this one topic, and I'll link it below if you want the longer version. Here's the accurate current state of evidence. The largest recent meta-analysis, 22 trials, close to 1,800 kids, was published in 2023. And it found that when you pull every trial together, omega-3 did not produce a statistically significant improvement in core ADHD symptoms overall. But that headline, it actually hides an interesting part. And when you isolate just the trials that ran for 4 months or longer, there was a real statistically significant small to moderate benefit. So the duration mattered enormously. And on the dosage specifically, it's a little murkier than I'd like. An earlier, smaller 2011 meta-analysis found a genuine dose-response relationship with EPA doses. There's EPA and DHA in omega-3 fatty acids. Those are the main ones. And the doses of EPA that mattered were somewhere around 450 to 600 milligrams a day, and these were linked to the biggest effects. But the newer, much larger analysis didn't replicate that dose dependency at all. So the length of treatment is well supported, genuinely important. The evidence backs that up very clearly. The idea that a specific dose is the magic number is still contested, and I'd rather tell you that honestly and pretend that the science has actually settled it. So the next one, vitamin D. And the association here is honestly stronger than I expected going into researching about this. Kids who are vitamin D deficient have close to double the odds of an ADHD diagnosis compared with kids who are not. And separately, kids who already have ADHD tend to have measurably lower vitamin D levels than kids who don't, on average. Supplementation trials have also shown that real improvement in the total ADHD scores and specifically with inattention, but hyperactivity scores didn't move so much. So it's really just inattention that is influenced by vitamin D, and that's actually meaningful. It's a specific finding. It's not just a vague, hey, vitamins are good for you claim. Is the third one, and this one I think is really underrated because the overlap is so direct, it's almost a joke. Poor sleep produces daytime inattention, irritability, and reduced academic performance that looks symptom for symptom an awful lot like ADHD. In some kids, treating an actual underlying sleep disorder, such as sleep apnea, where taking the tonsils out fixes the airway, leads to real improvements in daytime attention and behavior. That said, I really want to be precise here. Fixing sleep alone usually doesn't fully resolve someone's core ADHD symptoms if they genuinely have the underlying condition. It's a real contributor, not a cure, and definitely not a replacement for a proper evaluation. And ferret in your iron stores rather than the iron circulating in your blood. Kids with ADHD tend to run lower ferritin than kids without, even when they're not clinically anemic. And there's trial evidence that correcting that with supplementation reduces symptom scores in some children. And I do want to put a safety flag on all of this because it matters. None of this is about skipping a doctor and just taking supplements. Vitamin D and iron are both things you can genuinely overdose on if you're not careful. And it's important to know why the levels, particularly of iron, may be low in a child, because there could be an underlying diagnosis causing that in the first place. So this needs an actual blood test and a doctor involved, not just guessing at a dose from some video. Correcting a real measured deficiency is a completely different thing from self-medicating blindly. Putting it all together, this is exactly why I push back a little bit on calling ADHD purely polygenic. It's multifactorial. Genetics likely sets a predisposition, maybe even a threshold, but a cluster of ordinary, checkable, correctable physiological factors such as sleep, vitamin D, iron, omega-3 status can genuinely shift where someone lands on that severity curve. For some kids, correcting a real deficiency meaningfully reduces the symptom burden. That doesn't mean it obviates every case or replaces treatment for someone with a genuine severe presentation, but it means that the full picture is a lot more actionable than you either have the genes or you don't have the genes. I also want to touch on another layer, another thing, because I think it's the part that people get most defensive about, which is understandable. There's research looking specifically at ADHD content on TikTok, and it found that fewer than half of the claims in the most viewed videos actually line up with real clinical diagnostic guidelines. And that's a real accuracy problem, and it's worth naming honestly. But the same body of research also finds that social media has genuinely reduced stigma around ADHD, and that has helped a lot of people, particularly women who were missed entirely as children, recognizing something in themselves and actually going and getting a proper evaluation. Now that's a real measurable benefit, and those two facts aren't in tension with each other at all. They're both just true for different people and often at the same time. So here's where we are at the end of video 1, and I think it's actually a useful place to stand even without a final answer. There's decent evidence that ADHD as a label might actually be covering two different things at least: a genuine, lifelong, involuntary neurodevelopmental condition on one hand, and a culturally shaped, more voluntary kind of distractibility on the other. The brain science gives us real mechanism, but not a way to cleanly sort people into those two categories. And the online conversation around it is simultaneously spreading misinformation and doing real good at the same time. And if you take nothing else from this one, take Kathleen Stock's actual diagnostic question with you. Not, do I get distracted, but does it feel like I've lost the remote control, or does my distraction have a reason behind it? And that's a genuinely useful thing to sit with, whether you conclude, with whatever you conclude about yourself. And next time, I want to tackle a question I think a lot of you are already asking, because I certainly was. Do the medications actually work the way we assume that they do? Do they make you learn better? Do they make you remember better, genuinely perform better? Or do they just make you feel like you're performing better? And this is really not a rhetorical question. There's real controlled data on this, and honestly, some of what I found surprised me in both directions. I'm not here to tell anyone their diagnosis is or isn't real. I'm here to actually go through the evidence with you properly. This is part 1 of 4. I found enough while researching this that it split into an extra video along the way. So I'm going to see you in part 2. So for now, stay well. Ciao for now.